just briefly talk for 10 minutes or so about outcomes after what's called transcatheter aortic valve replacement and whether or not there's a sex difference. Just as a reminder, the aortic valve is one of the four valves in the heart that allows blood to leave the left ventricle and go out the aorta to the rest of the body, and then it closes and prevents blood from leaking back into the heart. This valve can become thickened and calcified and narrowed, what we call aortic stenosis, which leads to buildup of pressure in the heart and eventually heart failure, and patients develop symptoms of chest pain and heart failure and syncope, and ultimately will die from it without treatment. We've learned that there's a long latent period where people can have aortic stenosis, and then ultimately once they develop symptoms, there's a real steep drop-off in survival with medical therapy alone, and surgery is really the gold standard for treating these patients. These are data from the 1960s, but even with more quote-unquote modern medical therapy, there's still a very high mortality rate in patients with severe aortic stenosis who don't undergo surgery. Basically, even worse survival rates than what we see in many cancers. So for that reason, surgical aortic valve replacement involving a sternotomy, cardiopulmonary bypass, often lengthy recoveries, has been the gold standard treatment. And there has been interest in sex differences in outcomes after surgical AVR. This is one study of 408 consecutive patients, 192 women and 175 men who underwent surgical AVR at a center in Vienna. And overall, there was no significant difference in survival. And this is just one example. There's some other studies that have shown even lower survival rates in women. And so that's sort of been the background with respect to sex differences and aortic valve replacement. And we'll talk a little bit about what happens with transcatheter aortic valve replacement. Aortic stenosis is a disease of the elderly, and so 3% of those over 75 have at least moderate or severe aortic stenosis, and when you get to patients over 85, up to 10% have severe aortic stenosis. And what we've seen in the past is that a third or so of all patients who have severe aortic stenosis don't undergo definitive therapy with surgical replacement, either because of actual risks or perceived risks. And so there's a large group of patients that are being undertreated. And a little more than a decade ago, a less invasive technique was developed to help address these groups of patients. And it's called transcatheter aortic valve replacement, and what it refers to is inserting a catheter or tube in the leg vessel and running it up around the aorta across the aortic valve, and then deploying a new valve within the old valve. And the new valve is shown up here in the corner. It's like a cylinder, a stent basically, with the valve leaflets already sewn inside. And once you deploy it, then you remove the delivery equipment, and the new valve basically sits there and starts functioning immediately. And the patient, you just suture up the puncture site in the artery in the leg, and that's it. And the recovery is much quicker, and patients get out of the hospital much quicker, and you can treat patients who otherwise wouldn't be eligible for valve replacement. We've been doing it here at Stanford for about 8 years and have treated 700 or so patients this way and have been very impressed with the results. One of the studies that we participated in was called the Partner Trial, and one part of it included patients who were too high risk for surgery, and they were randomized to either this new technique or medical therapy. And you see the 5-year mortality rate was significantly lower in the TAVR group, the patients that got the transcatheter valve replacement, compared to medical therapy. And so this has now become the standard of care for patients who aren't candidates for traditional surgery and have severe aortic stenosis. There also have been studies comparing TAVR to surgical aortic valve replacement in high-risk patients who are eligible for open surgery but are just at high risk. And in this one study, TAVR outperformed surgery with lower rates of death at 1 year. Now, there's been interest in looking at sex differences in people undergoing transcatheter aortic valve replacement. And in this study that compared TAVR to surgical randomized, basically, patients to TAVR or surgical aortic valve replacement, when you look at the outcomes in the women alone, they had significantly lower rates of death at 2 years compared to the women who got randomized to surgical aortic valve replacement. On the other hand, when you look at men, initially they seemed to do a little better, but then the curves crossed, and by 2 years, the death rate was not significantly different, but numerically higher in the TAVR arm compared to surgical valve replacement. So this begs the question, are the differences in the women because they're doing better with TAVR, or do they just do a lot worse with surgery? And so subsequent studies have looked at that by comparing only patients undergoing the minimally invasive transcatheter valve replacement. This is one study from a couple centers in Canada that had 641 consecutive men and women and showed that the women did better as far as survival rates at 2 years compared to the men who underwent TAVR. A larger meta-analysis of a number of small studies in the literature compared over 5,000 women undergoing TAVR to over 5,000 men, and the early outcomes look a little bit worse in women in that there's a higher stroke rate, more major bleeding, more vascular complications, a little less need for pacemaker, and a little less what we call paravalvular leak or aortic insufficiency around the valve. But despite those higher complication rate, the, again, survival rate was significantly better in women compared to men. There, again, in this partner study that Stanford participated in, there were a number of studies that made up the whole partner trial, but this sub-study looking at all of these studies included over 1,200 women and 1,300 men. And I guess one thing to highlight is that it's rare in cardiovascular medicine where you have a study that has almost the same number of women and men. In most cases, it's far fewer women, so this is a bit unique in that sense. And again, this study showed that the mortality rate at 1 year was significantly lower in the women compared to the men. Now, it's interesting because at baseline, the women had higher predicted risk of mortality. Their clinical characteristics suggested that they would do worse based on other medical conditions. And just like that other meta-analysis I showed you, in fact, their initial complication rate was higher. They had significantly higher bleeding complications and vascular complications. But despite this, with adjusted analysis, adjusting for these baseline characteristics, female sex was independently associated with lower mortality compared to male. And the editorialists from this paper, which is just in press, questioned whether there's some pre-surgical imaging that could be done to identify a patient with aortic stenosis who's likely to respond with more favorable remodeling of the ventricle. Maybe it's something about women or some patients that we can identify ahead of time that will predict who's going to do well and who won't. And so, in fact, that's something that we've been working on. Yukari Kobayashi led these analyses under the direction of Francois Haddad, and Brian, Yuhei, and Keegan all helped out with this too. The objective being to evaluate sex differences in left ventricular function before and after TAVR. The idea being maybe women are able to adapt to the pressure overload from the aortic valve narrowing in a better fashion than men. And so there are a number of ways of looking at left ventricular function. Sort of the classic technique is what's called the ejection fraction, or looking at the amount of blood ejected with each beat. That's a bit qualitative and subjective, and a technique that Francois has helped to spearhead called global longitudinal strain is a more quantitative objective measure. Strain represents the magnitude of myocardial deformation, basically how well the ventricles contract, or the muscle is contracting. And the longitudinal strain is sort of the contractile deformation of the ventricle throughout the whole ventricle. And the lower the GLS, or this global longitudinal strain, the better the function. In this pilot study that we've been doing, almost 100 patients, 41 women and 57 men who've had TAVR here at Stanford, we found that at baseline, this global longitudinal strain, or GLS, was less impaired, meaning their function at baseline was better in women compared to men, minus 14.6 versus minus 12.2%. During follow-up, the GLS seemed to improve in an equal fashion in both women and men. So if you look at baseline 1 month and 1 year, both groups significantly improve, which is a good thing, and in a similar degree. And this is a little bit skewed because men are starting at a more impaired function to start with, there's greater opportunity also to improve. But in any case, it doesn't appear that women are doing better because they're improving better. It may be because at baseline their LV function is less impaired. We have looked at clinical outcomes. I mean, this study is underpowered to do that, but numerically we do see similar trends to what other studies have shown where women seem to have better clinical outcomes as well. So we still have a lot of work to do in this area, but we can conclude that women have improved survival after transcatheter aortic valve replacement compared to men. This seems to be unrelated to baseline clinical characteristics. If anything, we would predict that women would do worse, and maybe some of this has to do with our predictive algorithms and being skewed against women. But in any case, despite this higher apparent risk, women seem to have better myocardial adaptation to AS, which may explain their improved survival. Thanks for your attention.